able to see the recording from this morning session. So just since I have the recording running, I'll just say for the record, this is the week 12 review session for the exam 3 and lab practical 3. There were a few questions about, since people have a lot going on, that will the recordings be posted? Absolutely. I'll try to get them. If not tonight, then definitely tomorrow morning, this meeting should be up and running. So what I'll do, I'll just make a start, but at any time, feel free to shout out or write to the chat. But there's a couple of things I really want to highlight. Nothing too dramatic differently from what we've talked before, but just this is the probably most important for me, that I don't want anyone to worry. So I just want to make sure that everyone has heard the same things that what's going on. So you remember last week's deadline for the assignments that was extended to the end of next week. Let me take the calendar, and to the 18th, which is gonna be end of today, Wednesday, 18th of next week. And then we have the week before that deadline also to the Wednesday next week. Not this week, but next week. So if you need more time for any assignments, let me know. But both of those should have plenty of time. My goal is that you are able to study these materials before you take the exam. And in terms of what we're doing this week, we have the exam 3 and we have lab practical 3. For both of those, you have whole this week and next week to submit those in. So I want to make sure if you're still studying some of the material from week 11 or week 10, that you have a chance to study that material through before you're taking the exam. So that's why I have whole 2 weeks for submitting this exam and this lab practical in. But if you need more time, you just let me know. Of course, if you're able to submit earlier, I encourage you to do that. We're still going to keep moving. Next week, we're moving to the next chapter, which is going to be a digestive system. So just a heads up about the deadlines. This is just a quick look what we're doing today. Really, I want us to focus on the exam 3 study guide. So that's the most important thing for me, for us to have a look of. And the study guide should be the blank version posted already at the Canvas. If you have a chance to download it or print it, that might help. I will go through the answers to that. Some students don't learn that way. So if you learn in another way, taking notes or listening or just reviewing the video later on, whatever works for you. But you remember that for the exams, all the questions are from study guide. And you can use your notes, you can use your materials, you don't have to do respondus, and you can do it from anywhere you wish. Same goes for the lab practical, that it's again open book, and you can use your notes, you don't have to have a respondus on there. So just know that, don't make your life more difficult than it has to be. Quickly, I'm just mentioning, can you believe after this week, we've gone 3/4 of the semester. So we only have 3 chapters to go through, and then we're done with the material. There's going to be one last exam, and then there's going to be the finals week. And I'll talk about the finals week a little bit more once we get through this week's materials. So that's probably going to be next week or shortly after. But it's not going to be something that you have to memorize things or study things. I know that you have a lot of exams and a lot of things going on. So finals is your way to use whatever method you prefer to show me that you've learned something during this course. No new assignments this week. So only the exam and only the lab practical. But like I said, if you need more time to catch up with week 10 or week 11 materials, I really do encourage you to use this time that you have to catch up on those. I would take the exam 3 and lab practical 3 once you've gotten through materials from week 10, week 11, but it's up to you. I just want to make sure that you have enough time to do all that. The deadlines, exam 3 and lab practical 3, like I said, you have 2 weeks to do those. Notice that exam 3 is 100 points, lab practical 50 points. So if you want to strategize, that might give you a clue. I think that doing the exams and lab practicals really adds up to your overall points. So I encourage you to do those. There is the study guide for the exam 3. And what I'm going to do next, we're going to jump right to it, since I know that few people have other things that they have to attend as well. So that's why I'm trying to just move quickly along. Let me open up the study guide. Or I have it open, but share it with you. And it should be coming to your screen if it's not already on your screen any moment. Now, I'm going to zoom in a little bit so you have room to, or you have a better view of what's going on. I won't make too much annotations, a couple of things I might highlight. But really, I think that we're just going to jump right into it. If at any point you have questions, you have to shout out something, feel free. If I don't notice it, just turn on the voice, but I also try to monitor the chat at the same time. So let's start with the chapter 22, which was our respiratory system. And what I try to do normally at the beginning, like you've seen, is kind of have some sort of a connection, that how do these all things relate to each other, to the chapters that we've seen before, some systems links. And we talked earlier on about the cardiovascular system, and how would cardiovascular system then relate to our respiratory system? Well, cardiovascular system provides the transport means for transporting, for example, those respiratory gases. But it transports also a lot of other things. We saw nutrients, waste products, hormones, and so on. But really, the function of the cardiovascular system from the point of view of the respiratory system is to be the workhorse that then transports whatever gases we pick up and transports them wherever we want to dump them to. We also talked about the lymphatic and immune system. One example of that we looked at were the body defenses. So, for example, if we end up breathing in pathogens to the respiratory system and getting them there, well, this lymphatic and immune system plays a role in protecting us against those. We will have a look of the urinary system. We've kind of covered it already at this point, but I'm just coming back to it a little bit later. Urinary system, how it relates to the respiratory system is that it helps us to regulate things. And in this case, it helps us to get rid of the hydrogen ions that we might end up building up. And hydrogen ions we would, for example, build up as a result of cellular respiration. So this is just really an introduction. I wouldn't worry too much that you would see too much questions about that in the exam. That's just to get us thinking. But really what we want to notice is that respiratory system is very, very important for us. And if we think of the 3 major things that we attend to in a clinical practice, if we get a patient that we need to ensure, we want to make sure that the airway is open. Then we want to look at that, is breathing happening? If not, we're assisting the breathing with the mouth-to-mouth breaths. And then we look at the chest compressions if necessary. If the cardiovascular system isn't working, the heart isn't pumping. So you'll notice that out of these 3 vital things that we have to achieve, 2 are related to the respiratory system. So that tells us that respiratory system is going to be very, very important for us. You also see here this nice formula about cellular respiration. I'm not expecting you to memorize this formula. I think you've seen it plenty of times before, but what we see is that sugars, in this case glucose molecule, and oxygen are broken down, and we end up as a result with energy in shape of or form of ATP, and as a byproduct carbon dioxide and water. So what we want to see from this formula is that, okay, we need oxygen. Oxygen is going to be important for us so that we can do cellular respiration. And if you want to be really simplifying things, cellular respiration is all your body does. So we need to find a way. How are we going to be able to how are we going to be able to get the oxygen to the tissues where they're needed? The other thing that we notice, we end up with this waste product of carbon dioxide. So now we're going to be considering, in terms of the respiratory system, how do we get rid of it? How do we take the carbon dioxide out of the body? So those two respiratory gases are going to be super important for us to address. So as you see, the supply of oxygen is one of the main goals of the respiratory system, and removal of carbon dioxide. The respiratory system serves many other purposes. Some that I've listed here is, for example, the olfaction, so sense of smell. Sense of smell is really important once we get to the digestive system, that we are controlling what actually gets taken in, for example, as food. Is it edible? Is everything okay in terms of that food that we face? Another one, a lot of our communication in the modern world relies on speech. So that's also where respiratory system plays role. There's other non-respiratory functions that we might list, and we'll have a look of those a little bit later. Let's have a look of the parts of the respiratory system, and we will come back to these parts. We'll go through each one by one, but I just wanted us to have a kind of a roadmap that we know what we're going to be looking. Of course, we have the first part of the respiratory system and most anterior part of the respiratory system, our nose. And in addition to our external nose that we can notice, we've got, of course, internal parts, and then behind that, the nasal cavity. We also will mention a few words about the paranasal sinuses. They're included in the exam material. And we'll notice that we also have pharynx. Pharynx started behind the nasal cavity, continued behind the oral cavity, and all the way down to laryngopharynx, the area above the larynx. Larynx instead was where our voice box is located, so voice production, huge contribution from here. Trachea, our windpipe, carrying the air to the lungs. And once we get to the bottom of the trachea, where it divides into two, we end up with our primary bronchi. The bronchial tree divides multiple times. We get eventually bronchioles, and we will be looking at alveoli as the very last step. You'll notice that lungs are also something that we'll have to discuss a little bit. All of these would make great topics for the exam, and I'll highlight where something of interest comes up. Let's have a look at the nose, and I'm just gonna put it here so I'm able to see the same amount of stuff as you guys are seeing. I've got some additional screens that are popping up. So, nose is the most anterior part, and most of the time, all of the air intake happens through the nose. By default, that should be our main route of entry for the air to the body. Sometimes when we're not getting enough air through the nose, we might also recruit mouth if there's a significant need for additional amount of air to come into the lungs or get rid of the air from the lungs. So that's when we recruit the mouth. But by default, at the normal state, it is through the nose that we try to breathe. I always think of if I see in face-to-face class a student yawning, that what is the physiological reason behind it, rather than thinking that maybe there's psychological elements of boredom or something like that. Well, the physiological reason would be if our body notices that we're not getting sufficient amount of oxygen, our body comes up, our brain sends a signal that we need to now somehow get large amount of oxygen into the body. And the best way we can do that is by opening the mouth and taking a deep breath in. That's where the yawning steps in. So that's where we recruit both mouth and oral cavity to take in that additional oxygen quickly and in large amounts to the body. So that's what I'd be looking if I were to ask anything about yawning in the exam. We're looking for the physiological explanations, not the psychological aspects. What else do we need to know about the nose? Well, of course, we've got our nostrils. The Latin words nares and nares have become fairly commonly used. Notice that nostrils have right at the first part bunch of hair there. The hair might be more visible or less visible. The amount of hair can vary. Usually in older men, we end up seeing thicker hair. The function of the hair is to filter the air. So we remove any large particles that would enter to the respiratory system by this first mechanism that we have. Then we get to the nasal cavity. What do we need to know about nasal cavity? Well, nasal cavity is not lined by skin. There's a different kind of a lining there, and that's going to be our mucous membrane. You'll notice that mucous membrane is much thinner than the skin. It's covered with this surface being sticky and also being very humid, kind of a wet surface. The idea or the function for that, one of the main functions for the stickiness of the mucous membrane is that this can trap particles. So whatever doesn't get filtered by the hair, well, now we're trapping these particles at the nasal cavity, and they're getting trapped to the wall of the nasal cavity, which was lined with the mucus. There's a few other functions with the mucous membrane. The fact that it's thin, there's rich blood supply that allows us to heat up the nasal cavity and air that passes through the nasal cavity. Same as the fact that it's so humid, it allows us to make sure that the air that enters to the lungs or enters to the respiratory system further, it's humidified enough that it's suitable for the parts that follow later on. But for our purposes at this point, we focus on the fact that mucus traps the particles that enter to the nasal cavity that don't get trapped at by the hair at the nostril. The mucus that we end up seeing, that's produced by the goblet cells, and we had a look of those in the actual lecture material. And what's interesting with the nasal cavity, and something that I think is worth noticing, is that from the lateral wall of the nasal cavity, so from the sides, there's actually 3 protrusions coming in. These are named simply based on their location: superior, middle, and inferior. And these are known as our conchae. So they expand from the lateral side to the medial side, not quite connecting with the medial nasal cavity. The function of the conchae is, first of all, it gives us more surface area. Remember, whenever we had these things that came out of the cell surface or in other purposes, well, this is a larger scale, but it still gives us more surface area. Why would we want to have more surface area? Well, we want to have more mucous membrane lining in the nasal cavity, so we have as much area to trap those particles that pass through the hair of the nostril. In addition, the shape of this conchae generates the airflow to be more mixed. So as much of the air as possible gets to touch the mucous membrane lining of the nasal cavity. So these conchae generate turbulence also within this cavity. So those are the two important functions of the conchae. And there were three of those. We also have mentioned there the nasal septum, which separates, of course, the left and right side. Remember, it's not very symmetrical. We see all these diagrams, but there's a lot more variability in real life. The base of the nasal cavity, the floor, if you wish, is formed by the palate. And you'll notice that there's a hard palate. If you try with your tongue, the most anterior part is the hard palate because there's actually bone inside. Their soft palate and the uvula them more posteriorly, and they serve a role of actually sealing off the nasal cavity when food, bolus, or liquid gets swallowed. We want to prevent that those don't enter to the nasal cavity. And we'll talk more about that when we talk about the digestive system. But anyone who has had, for example, soda or milk going through their nasal cavity coming out from the nose knows that that's not great. So that's the function of that. We need to talk a little bit about paranasal sinuses. And what I want to say is that you remember that the term sinus always referred in anatomy to some kind of a cavity or a space within an organ or within a structure. In this context, it's going to be these gaps within the bony structure of the skull. So let's go through. We've got 4 different kinds of paranasal sinuses. Many of them are actually symmetrical on both sides of the body, left and right side. But we're going to cover them as simply going through these 4. So first one that I want to mention are our frontal sinuses. Well, you'll notice that frontal sinuses are located within the frontal bone. So knowing the bones of the skull, all that work that you did earlier on is going to pay off now. You'll be able to name your sinuses based on that. Maxillary sinuses also on both sides. They are located within the maxillary bones, maxilla, and one on each side. Sphenoid sinus. We've got a singular one located within the sphenoid bone. So that's further back, so more posterior and also deeper to the skull. You really should probably, if you are struggling to think of where those were located, refer back to the notes, refer back to the diagrams that I provided. And the last one is sometimes known as ethmoid sinus or ethmoid sinuses. I prefer to use the term ethmoid labyrinth, because this is a bunch of sinuses within the ethmoid bone. It's not just a single sinus, it's not even 2 sinuses, it's a group of them and they're all interconnected. So to me, it really looks more like a labyrinth. You can use either term, but just something to bear in mind. Well, why do we have these paranasal sinuses? Some of the reasons are well agreed, and some of the reasons we're still debating and considering, but we will consider 4 different reasons. Some of them are more hypothetical, some of them are better established. But the first one, which is one that's very well agreed on, is that if our skull was solid bone and there were none of these gaps, none of these sinuses, there would be significantly more weight for our head to be carried up as well. And remember, the neck, the muscles of the neck especially are the responsible for keeping the head up. We're trying to reduce some of that workload by reducing the weight by having these sinuses within the skull. So that's one of the functions of sinuses. The other one that has been also fairly well shown is that your voice gets manipulated a lot after the voice box in other parts. And some of those parts that manipulate the voice of yours are also these paranasal sinuses. So they are a space where we can generate this voice resonance. So hearing a voice, whether it's a computer-wise generated or whether it's generated in other ways of modeling that, in a skull where there's no sinuses, there's a significant difference. So paranasal sinuses contribute to each one of our own voice that we put out and experience of the voice in terms of the voice resonance that takes place here. The third reason that we've discussed, that's a little bit more theoretical. That's somewhat still on a level of hypothesis. There's some more work to be done to establish the validity of this hypothesis, but that's something that we will consider on this course. So similar as you have the front of the car that's actually designed to collapse if you get into an accident. Similar, you have these paranasal sinuses. And why would this make sense to have that? Well, think of when cars are driving at the fast speed and there's an impact. Actually, the fact that the front of the car collapses helps us to absorb some of those forces that would be otherwise, if the front didn't collapse, put directly to the head, directly to the brain. So it has been proposed that the sinuses might serve similar reason as structures that can then collapse if there's a direct impact to the face, to the skull from the anterior side. That would then help us to reduce some of those forces, some of that impact. So they would serve a role in shock absorption. The last one, which we are still finding a lot more information, but is becoming more and more obvious to be one of the functions of the paranasal sinuses, is their role in the immune system. And like I said, we are fairly comfortable about that, fairly confident, but there is more to be learned about this. We looked during the class videos, we looked at a condition known as sinusitis. So from your medical terminology class, you remember when it's itis, it's an inflammation of something. In case of sinusitis, it's an inflammation of the sinuses. So that's probably all that we need to know about paranasal sinuses. I've listed here also a structure known as auditory meatus, an opening of the auditory meatus. So you'll find at the posterior inferior part of your nasal cavity this opening, and that's the connection to the inner ear. So there's a direct line, tube that runs there. And this explains, for example, when your ears get blocked or popped, when you're, for example, changing the altitude where you're at, for example, on a plane that's gaining more altitude or losing altitude as during the landing, or if you're driving, or whatever the reason, what helps you to pop your ears back is actually ensuring that this connection to the inner ear is open. So opening your mouth, swallowing, doing all sorts of movements there. That's why often people prefer to chew chewing gum when they're, for example, on a plane, or suck on hard candy, things like that. So we end up finding that structure there as well. And again, I refer you back to the diagrams if you're confused. Where was the opening of the auditory meatus? Well, now comes a really important part. We will consider the three functions of the nasal. And we've already seen the first one. We've already mentioned that few times, that the nasal cavity played a role in filtering the air that enters the rest of the respiratory tract. First with the hair at the nostril, but then later on with our mucous membrane lining, or mucous lining of the nasal cavity. We're trying to trap any particles that we don't want to enter further to the respiratory tract. That's the first purpose. Second purpose is to heat up the air that enters then to the down to the respiratory tract. So this related to the fact that we had a thin layer there, unlike skin, much thinner, and that's richly supplied by blood vessels. That's why nosebleeds are so common. So by having rich blood supply that comes in very close contact with the air there within the nasal cavity, that blood brings warmth, that brings heat from the core of the body, and we're able to heat up, warm up the air that will then continue further. Same process happens with the goblet cells secreting that mucus, which was very moist, wet. That helps us to moisten the air as well. That would continue further down the respiratory tract. So all those three functions really serve a purpose that whatever goes down the respiratory tract is going to be ideal for the functions that take place there. If you've ever gone out on a cold, dry winter day, taken a deep breath, you probably will start coughing. That's because you're not now necessarily breathing through nose. If you're breathing through mouth, that air is not going to be heated up. That's going to be cold and it's going to be dry. It's not going to have a chance to get moistened. So that's not ideal for our respiratory system, and your respiratory system will react to that. So this is the reason why we do tend to breathe through nose by default, because we're able to ensure that these three important functions are achieved by us breathing through the nose. So the function of the nasal cavity: filter the air, warm the air, and moisten the air that enters to the respiratory tract. The next structure that we should have a look of is our pharynx. We'll notice that pharynx is this skeletal muscle tube that really, and I need to change on this review sheet. I haven't had a chance to do this, but I noticed it in the morning. I probably would change it from starting from the back of the mouth. It really starts from the back of the nasal. And it continues all the way to the start of the larynx, so about the level of cervical sixth vertebra. And there's three parts that the pharynx gets divided. The part behind the nasal cavity is known as nasopharynx. The part behind oral cavity is known as oropharynx. And the part that's within where the epiglottis would be located when it's standing upright. So from the base of the oropharynx all the way to the start of the larynx is known as laryngopharynx. So those are the three parts, and we want to know where each one of them is located. Let's have a look of the larynx then. Well, what do we know about larynx? Larynx is a bunch of structures. It includes cartilages, but it also includes other parts that often gets overlooked. But notice that there's also muscles, there's also elastic tissue that contribute to the structure of the larynx. And we're going to focus on these cartilages that make up the larynx. Not that the other parts wouldn't matter, but these are the anatomically most visible ones, and these are going to give us a lot of good information for what we want to learn about. So let's start with the largest, most prominent one that forms the biggest part of the larynx. That's going to be our thyroid cartilage. How do you know where thyroid cartilage would be? Well, you already know where the thyroid gland is. And as I said, thyroid cartilage is very prominent. So you can even feel it here, see it externally or feel from the surface anatomy. And one part of the thyroid cartilage that's super easy to feel is the laryngeal prominence, so Adam's apple. And we, of course, remember that that's more prominent in men a lot of the time, but that's not always sure fact, so there can be some variation. So thyroid gland was an easy one. You can try on yourself, notice where it's at. If we continue down from the thyroid gland, you'll notice when you feel on your neck, there's a gap after that. And then we get another cartilage. This cartilage is the very inferior part of your larynx. And this is the cricoid cartilage. In fact, that's the only cartilage that forms a full circle out of the cartilages of the larynx. So fully closed ring. That's our cricoid cartilage. Let's look at some of the other cartilages that we find within our larynx. And let's go and have a look of the epiglottis next. So epiglottis was this flap-like structure located inside the thyroid cartilage, peeking out from the top of there, peeking up sometimes to the level of hyoid bone, sometimes a little higher. The function of the epiglottis was that you notice that it is open most of the time, but it closes, sealing off the trachea whenever we end up swallowing something, food or liquids or so on. So the function of epiglottis is to protect that we don't end up getting anything down to our windpipe. But because securing the airway being open at all times was so important, epiglottis is by default open. It only closes when we are swallowed. The next one, which is actually two similar structures, one on each side, one on left, one on right, again located inside the thyroid cartilage. These are these pyramid-shaped or triangular structures that have muscles connecting. And these muscles cause these cartilage parts to move. And why this is important is that these cartilages have vocal cords attached to them. So by moving these cartilage parts, we're able to manipulate the tightness of the vocal cords. And of course, these cartilages are known as arytenoid cartilages. Again, refer back to that diagram that I prepared for you if you're kind of lost what they are, where they're at. Well, on top of the arytenoids, we have corniculate cartilages. These are tiny tips on top of the arytenoid, again, housed inside the thyroid cartilage. And the last one that I want to mention is our cuneiform cartilages. These are not normally seen if you have a look of larynx that hasn't been dissected, hasn't been cleaned, you don't use some special medical imaging approach. These are actually embedded inside the mucous membrane lining of the larynx. So on each side, cuneiforms within the thyroid cartilage. What's the function of our larynx then? Well, let's have a look at that. Well, larynx, of course, air passes through there. It separates the root for the food and air, if you think of the function of the epiglottis. But really one important one that we want to highlight here is that this is where the vocal cords are located. And if you think of what vocal cords look like, they're these white elastic fiber bands. Why are they white? Well, they're white because there's no blood supply to them directly, so we don't get that reddish color. And you remember we have two vocal cords that are actually responsible for the production of the voice, and the space between these two is known as glottis, or if you want to be more anatomically accurate, it's rhimaglottis. And I said that there's two vocal cords. Above these actual true vocal cords, which are also known as vocal ligaments, which actually are involved in the production of this voice, and they resonate, they tighten, they loosen, changing the pitch of the voice. Above them, we've also got another set of something that looks like vocal cords but aren't quite that. These are our vestibular folds, and these are known as false vocal cords because they don't actually contribute to this voice production in terms of vibrating or being changed in terms of tension or anything like that. But two pairs of vocal cord-like structures. Then I want to say a few words about trachea. It's about 4 inches long tube, depending a little bit of an individual size and so on. But what you notice about the trachea is that it's made of C-shaped cartilage rings. And this C shape is important because they're open on the posterior side, and this allows, if the oesophagus, which is located posterior to the trachea, has to expand, for example, if there's a big piece of food, it can expand a little bit inside to the space of the trachea, or where the trachea normally would take the space. because the back of these cartilage rings is open. Trachea runs from the base of the larynx all the way to the mediastinum, where at the level of carina, it stops and divides into two primary bronchi. These primary bronchi are different in the angle how they enter the lungs. And we'll notice that the right primary bronchi enters the lungs in much steeper of an angle. This is going to be clinically important if we have, for example, children, young kids, they put everything they possibly can into their mouth and sometimes end up ingesting those. If they end up taking an object and it goes to the lungs, we often find it on the right lung because of the steeper angle of the right primary bronchi. The clinical relevance that I mentioned here was tracheotomy. So when we need to make an incision, if there's, for example, a blockage higher up on the respiratory tract for air to get in, often between our cartilages, I would say that we would look, for example, between the thyroid and cricoid cartilage, there would be a nice spot. You have to be quite careful when making an opening like this because there's a lot of blood vessels and there's important nerves running there. We don't want to injure the patient on that sense. Then we, of course, have our bronchi. We have our tertiary bronchi or segmental bronchi, whichever term you prefer to use, bronchioles, terminal bronchioles, eventually alveolar ducts, and alveoli at the very end. But what I want to highlight as the first point here is that where the primary bronchi enter the lungs, that spot is known as hilum. That's a good term to know. And what we'll notice when we study this bronchial tree, the actual anatomical structure of it changes, and as a consequence, the physiology changes slightly. So the amount of cartilage decreases as we move further down this bronchial tree, and the amount of smooth muscle increases. So the wall structure changes in that sense. Let's have a couple of things that we need to highlight about the lungs. Look of those. You remember we mentioned apex of the heart being the point of the heart, and it pointed inferiorly, anteriorly, and to the left. But apex can be located in an organ anywhere. It's just the sharp edge, the tip part of an organ. Well, in case of the lungs, the apex is actually the most superior part. It would be often the part that goes close or even is slightly past the collarbone, so very high. Lungs actually continue high within the chest cavity. The base then would be the structure, the surface that rests against the diaphragm, the part of the lungs that rests against the diaphragm. And we already mentioned this hilum, the site of entry and exit to the lungs where the primary bronchi entered and exited. I've also added a little bit of space so you can fill in more details, for example, defining the root as the vascular or bronchial attachment to the mediastinum. So that's the root of the lungs. Costal surface, that's the surfaces of the lung that attach, connect to the ribs. So we have that on the anterior side, lateral side, posterior side. So those are some to know. Let's have a look what else we could talk about lungs. Well, normally on a textbook, you will be told that the lungs are made of, on the right side, of 3 lobes. We have our superior lobe, we have our middle lobe, and we have our inferior lobe. And then you get told that on the left side, you only have 2 lobes, your superior lobe and your inferior lobe. The explanation for this is the fact that lung on the left side is much smaller. And that's smaller because the heart takes much of this space here and causes the left lung to be smaller than correspondingly. So you can see the cardiac notch is this part of the lung on the left lung where we can see that it's almost like a part is missing because that space is taken by the heart. We also can have fissures, and you remember fissures from our discussion of the brain structures, for example. The horizontal fissure runs on the horizontal line, and oblique fissure in an angle that doesn't align with any of our basic planes of the body. You would have both horizontal and oblique line. Within the right lung, on the left lung, only the oblique one. If you look at the diagram, you can kind of work out the directions of it. So this is what we teach to you with the textbooks, and this is what we will go by on this course. But in reality, humans are not always following the body structure, always following this. So if I have, let's say that I would have 5 catheters in a typical classroom where students would be working around catheters. Out of those 5, probably at least 1 would have a different number of lobes than what we've been teaching. You might have 3 lobes on the left side, or you might have only 2 lobes on the right side, or so on. So then what we're learning is averages, the typical ones. There is individual variation, so be aware of that. That's not something I'm going to test you on the exam, but I just want to put that to your mind, that you remember that what you learn is just generalizations. Well, we also remember that the lungs were closed within the pleural cavity. That's made of 2 layers. The inner one was our visceral layer, the outer one parietal layer, and in between those we have the pleural fluid. And the point of having this fluid between 2 layers is that allows, first of all, these 2 layers to slide past each other. Think of the cardiac sac that we had. So lubricates this. Also provides cushioning so that the lungs do have that room to move a little bit. But the most important function of the pleural cavity is that helps us to generate a negative pressure to this cavity. And this negative pressure in this cavity helps us to pull the lungs so that they're constantly expanded as large as they can be. If you have an individual who, for example, has a puncture to their pleural cavity, their lung can collapse. And that would be a problem for us, sir. Let's have a look at the alveoli. These were the very last small sacs. They're usually as a bundles of sac, groups of sacs within the lung. Small microscopic structures, about 300 million per lung. The function of these is that this is the site where the gas exchange really takes place. The wall of the alveoli are very thin. There's rich capillary supply close to these. So that's the business end where all this gas exchange takes place. Let's have a look what else could we think of. So that's the anatomy of the respiratory system. We're going to take a couple of moments to look at the physiology. And the phases of respiration are often listed as a pulmonary ventilation, external gas exchange, gas transport, and internal gas exchange. And you might find this diagram that I drew for your notes useful. It's in the lecture material that we've had a look. It's oversimplification, but some find it that might help. So let's go through what happens in respiration through this diagram. However, I do want to point that this would be the respiration as it goes taking oxygen into the body. This works the other way around as well. We get rid of carbon dioxide and take it out from the body. So the order 1, 2, 3, 4 doesn't mean that would be the end of it. Then we can go 4, 3, 2, 1. So maybe the numbers are not the best way of listing this, but there's 4 phases. That's what your textbook says, and that's how we approach it. So let's have a look at the first phase. First phase was called pulmonary ventilation. This refers to taking the air from the outside the body and getting it into the lungs and within the alveoli of the lungs. So that's what happens in the pulmonary ventilation. And we can have different kinds of respiratory movements. Let's have a look at those. When we breathe in, we can talk about inhalation or inspiration. So getting air in to the lungs. That is actually the part of the breathing where we have to invest energy. So that's the active part of breathing. Your external intercostal muscles help by pulling the ribs so that they move outwards and upwards. But at the same time, the main respiratory muscle, diaphragm, changes its shape. Normally, diaphragm at the relaxed shape is kind of a dome-shaped sheet of muscle separating the thoracic and abdominal cavity. When diaphragm contracts, it actually straightens out and goes downwards. Both these external intercostal muscles, and especially the diaphragm going downwards, causes our chest cavity to grow. As a result, the lungs expand, and when the lungs expand, the amount of air that we have inside the lungs now occupies a larger space. So the pressure within the lungs decreases. There's a low pressure inside the lungs. Well, you remember how gases move. They always move from high pressure to low pressure. Now, in comparison, the outside air is going to be high pressure in comparison to the low pressure of the lungs. Well, air is going to move from high pressure to low pressure. Air flows into the lungs. So inhalation is an active process. We have to move these muscles to make our chest bigger, make our lungs bigger, so we get air in. When you take a deep breath and then fully relax, air flows out. So expiration, breathing out, is a passive process. You don't need to recruit any muscles to make that happen. That just happens due to the elastic recoil, and of course the surface tension contributes to that. However, although the expiration normally is a passive process, you can go beyond the amount of air that would normally leave your lungs, and you can really blow air out. Well, that's forced expiration. To make forced expiration, where we actually get rid of more air than we normally would get rid of, we recruit muscles. We have our oblique abdominal and transverse abdominal muscles, and we of course have also our internal intercostal muscles contributing. What we're doing in expiration or forced expiration is that we're making our lungs smaller. Our chest cavity is becoming smaller again. Our lungs are decreasing in size. Now the same amount of air that's in your lungs has less space to occupy. So there's higher pressure inside the lungs. And in comparison to the outside world, there's lower pressure there. So air always moves from areas of high pressure to low pressure. Air flows out from your lungs. So those are our respiration types. Let's have a look at what happens after we've gotten this air to our alveoli. There's more to do. We're not finished yet. We need to move the gases from the alveoli to the capillary at the pulmonary system. The capillary is the blood vessels that run right next to the alveoli. This is known as our external gas exchange. And how we move gases from alveoli to the blood or from the blood to the alveoli is by partial pressure differences. So again, from areas where there's high pressure, gases move to the areas of low pressure. And we'll have a look at this a little bit later, but I do want you to remember that the driving force for gas exchange, whether it's external or internal, is partial pressure difference. And the reason why we call this external gas exchange, that this is the first time when the gas exchange takes place, and this is closer to the external level. There's going to be internal gas exchange where we're exchanging the gases between the blood and tissues in the body in the systemic circuit. So this is within the pulmonary circuit. Well, let's have a look at what happens after that. Gases must be transported. So gas transportation is the third stage. That's where we're moving the blood within the vasculature. Now, once we've finished that, we get to close to the tissues. Blood is now in the capillaries of the cardiovascular system, and it's time for internal gas exchange. Oxygen moves to the tissues, carbon dioxide moves from tissues to the blood. So that's the direction of changing the gases. We also have a bond, and then of course we would go back in a reverse order to get rid of the carbon dioxide. This is how we got the oxygen to the tissues. In terms of other things to mention, we of course have a bunch of other non-respiratory air movements. I think this yawning that we talked about earlier on, I would probably list it actually as a respiratory movement in a sense. So I would probably put that in brackets. I'm still fine-tuning this study guide. So if you want to adjust your ones, I would probably end up still putting it in brackets. But a lot of other things that we can do that don't really contribute to the respiratory, but cause air movements, coughing, sneezing, crying, laughing, hiccups, things like that. So what else should we know? A couple of terms. Surfactant, that was the mixture of lipids and proteins that reduced the surface tension and importantly prevented the alveoli from collapsing, kept them in their shape. Compliance, there's a more complex definition, but the definition that I'm going to use and encourage you to use is that compliance is simply the measure of the stretch that the lung has. How do we assess ventilation? How can we study that? Well, the machine that we use for that is our spirometer. There's more advanced and less advanced ones, but the basic concept is the same. We're measuring the amount of air and which direction that air is moved. So we're going to go first through 4 respiratory volumes. And to go through them, we're going back to this diagram or this graph that I've drawn for you in your lecture materials. So I would refer back to that if that you find that might help you. So let's start with tidal volume. That's the amount of air that moves in and out in normal breathing. So you'll notice that in normal breathing, we don't use all of our capacity of the lungs. Fairly little air moves in and then out and in again. It's somewhat, I would say, 500 milliliters based on this graph for one breath. But we can breathe in more air than this. And this is known as inspiratory reserve volume, IRV, when we actually get in the maximum amount of air that we possibly can into the lungs, beyond the tidal volume. So tidal volume is not included to the volume of IRV. Well, we can do the same, the opposite direction. We can expel more air than we normally would. So this would be known as our ERV, expiratory reserve volume. And you'll notice that these are much larger volumes than our typical TV tidal volume. And then there's always going to be some air there that doesn't leave the lungs and remains in there. That's our residual volume. So those are the 4 volumes that I'd like you to be familiar because they help you to understand the respiratory capacities. And you'll notice that when we're going to talk about respiratory capacities, we again find ourselves looking at the same graph that I provided to you earlier on. So respiratory capacities are calculated by combining different combinations of volumes. So the inspiratory capacity is the amount of air that we can get in to the lungs in maximum. So that includes the normal breathing, so our tidal volume, plus the IRV. So that gives us our inspiratory capacity. Well, here I have a spelling error. It should be functional residual capacity. So if you want to fix that to your notes, I encourage you to do so. FRC, you can calculate the functional residual capacity by adding the residual volume and your ERV, so expiratory reserve volume, together. That gives us our functional residual capacity, how much air normally would remain within the lungs with just normal breathing, without doing any extra effort. Well, the next one is our vital capacity. Vital capacity tells the amount of air that we can maximally take in and maximally blow out, plus the normal breathing. So it's a combination of our tidal volume, our inspiratory reserve volume, and our expiratory reserve volume. All of them added together gives us our vital capacity. And if we add to this also the residual volume, the amount of the air that always remains in the lungs, and we add it to everything else that we already added together, we get the total lung capacity. How much air can be in the lung in total at max? So that's our TLC, not the band, not the TV channel either. So those are our volumes and those are our capacities to be aware of. We mentioned that some air always remains within the lungs. That's known as our dead space. So we have anatomical dead space. That's the air that remains within the passageways. And alveolar dead space is the amount of air or the amount of space occupied by the alveoli that no longer work. There's some sort of a damage to them. For example, they're collapsed. Or there's, as a result of smoking, it damaged there. So if you add the anatomical and alveolar dead space together, you get the total dead space. So what doesn't contribute to the breathing movements? The next thing that we're going to talk about, we're going to look at the gas exchange. To appreciate gas exchange, I encourage you to look at these diagrams that I drew for you and I have included on the side of the handout. They help us to appreciate what are we talking about when we already earlier noticed that the driving force for the gas exchange was the partial pressure difference. So let's start with the external respiration. So change of gases between the lungs and blood in the pulmonary circuit. Well, what we do when we want to look at the partial pressure differences, we measure these for each gas separately. So let's have a look of the oxygen, partial pressure of the oxygen that enters to the lungs in blood. Well, the partial pressure of oxygen entering to the lungs is about 40 milligrams of mercury, whereas in the air around us, it's 100 milligrams of mercury. So you remember the partial pressure difference was the driving force, and we always went from areas of high pressure to areas of low pressure. So oxygen moves from the alveoli to the blood capillaries in the lungs. Well, the opposite happens for the carbon dioxide. Blood returning to the lungs, it has partial pressure for carbon dioxide of 45 milligrams of mercury, whereas in the air around us, it's 40 milligrams of mercury. So we move from areas of high pressure to areas of low pressure. So carbon dioxide leaves the blood. And now you'll notice that the blood that leaves the lungs has the same partial pressures for oxygen and carbon dioxide as we saw in the air around us. So we've taken as much oxygen as possibly can be taken, and we've gotten rid of as much carbon dioxide as possibly can be gotten rid of. Well, now this air travels to the tissues in the systemic circuit, and we're looking at the exchange between the blood and tissues. This is, of course, our internal respiration. So the amount of oxygen, the partial pressure of oxygen arriving in the blood to the systemic circuit and to the tissues is 100 milligrams of mercury. Whereas within the tissues or within the interstitial fluids, it's only 40. So gases moved always from the areas of high pressure to the low pressure. So oxygen moves from the blood to the tissues or to the interstitial. The reverse is the case with the carbon dioxide. In the blood, in the systemic circuit, we've got 40 milligrams of mercury as the partial pressure for the carbon dioxide, whereas within the tissues, it's about 45. So gases move from the areas of high pressure to the areas of low pressure. So from the tissues or interstitial fluid to the blood, to the capillaries. And then we return back to the beginning of this diagram that we saw here. So you'll see it is a loop and we move as a circle back and forth, exchanging these gases. But the driving force is gonna be, like we saw here, the partial pressure difference. That's gonna be the important factor that determines what moves and where, and how much of that will move. Final thing that I want us to look in terms of the respiratory system is how do we transport these gases in the blood? So we're slightly referring back to what we had a look already when we discussed about the blood and cardiovascular system. Well, we remember that most of the oxygen was transported in blood bound to the hemoglobin. However, most of the carbon dioxide is transported in blood as bicarbonate. Some of it, yes, was bound to the hemoglobin as well, and some dissolved in plasma, but most of it is as a bicarb within the blood. The clinical relevance that I mentioned here was hyperventilation. I'll let you refer back to that and make your thinking about it if that's something that you don't recall what we discussed about when we talked about the hyperventilation. So that concludes our chapter on the respiratory system. You've seen that I spent a lot of time on it. So respiratory system must be an important part of our exam content. We'll also have a look of the urinary system, but you'll notice that we'll go through it much quicker. That tells us that I'm not saying that urinary system is not important, but to go through the material there's less of important points that I want to highlight. And then finally, we'll touch upon the fluid, electrolyte, and pH balance as the last chapter. But it shows you that respiratory system was something that we really, really do want to focus. So, with that said, let's have a look what we can say about the urinary system. Well, urinary system has many functions, and the business end of the urinary system is, of course, going to be our kidneys. So we'll start by spending most of the time looking at kidneys, and especially on more microscopic level, the important components of the kidneys. But I do want to kind of orientate us by noticing some of the functions of the kidneys and picking up a couple of important things from here. So you remember we talked earlier on that blood pressure was regulated by the kidneys. So that's definitely an important function for us. The other important function that we'll notice is that the fluid or water balance was regulated by the kidneys. And we'll talk about solute concentration or ion concentration a little later on this review session as well. But all of those are functions of the kidneys, what kidneys do. And then there's a bunch of other ones that I've listed there. You can have a look at those independently. Well, let's have a look at the anatomy of the kidneys. There's not a lot on here. Let's keep it simple. And let's start with the external anatomy. When I ask what kidneys look, I often get a description that they look a little bit like beans, just much larger, of course. They are on the medial side always concaved. So they have this smaller curvature. And on the medial side, we see this renal hilum, where the ureter joins, blood vessels join, nerves join, all of these enter and exit to the kidney from the medial side. On the lateral side, we notice that kidneys are more convex. So we have this larger curvature. And this is always the case on both, on left and right side. The medial side is going to be our concave side, and that's always facing the middle of the body. When we study the kidneys and look at them, they seem incredibly smooth from the surface. And that's because they're enclosed within a renal capsule, this fibrous tissue layer inside it. And if we want to use our anatomical reference points that we've talked before, we can think of back to our peritoneum, and we'll notice that kidneys are classified as retroperitoneal organs. So they're behind the peritoneum. In fact, kidneys are very far to the back of your body, much further than we often think. So again, an impact at the very back of an individual can have an effect on their kidneys. So they're not that well protected deep in the body. They're close to the back of your body. In terms of the height of the kidneys, you remember, of course, that the right kidney is located lower than the left kidney. And the explanation for that is that we have a liver located mainly on the right side above this, so that takes a lot of that space, and for that reason the right kidney kind of is pushed downwards. And we'll have a look of that when we discuss about the digestive system and have a look of the abdominal organs in greater detail. In terms of the internal anatomy of the kidney, a couple of things to note. We do have a cortex and medulla. We remember these from past. Cortex was the superficial part, medulla the deeper part. And within the medulla, we see these renal pyramids or medullary pyramids. These are these triangle-shaped structures that we see here. And we, of course, have our renal pelvis as well, the medial funnel-shaped structure that connected to the ureter. We already had a look of it here. What else could we mention? Let's have a look. I listed there the flow of the urine through the kidney. Good to know. And really what I want us to focus is a structure known as nephron. This is the business end of the kidneys. These are microscopic structures. There's loads and loads of them. And what we're going to do, we're going to review the parts of a nephron, and then we're going to look at the physiology in terms of the movements of the fluids. So nephrons are both structural and functional key unit of the urinary system. And how we're going to review the structures of the nephron, I've listed them here. And we're going to go through them on this diagram. And normally I would write them to this diagram, but because I have not figured out, I've lost the button that I normally use to write things on a PDF file, I'm just going to point them out with a cursor, and you can fill them in for yourself. That's simply because I have no idea how I managed to lose that tool. So let's have a look. What should we know first? Well, let's start with the afferent arteriole. This is the blood vessel bringing blood to the nephron. So you remember the word afferent, like arriving, entering in. And then, of course, if we have afferent arteriole, we're going to have efferent arteriole. That's the part that takes the blood away from the nephron, exits, if you wish to use my memory. So blood comes in and blood leaves the nephron. You'll also notice that this blood forms this capillary network, capillary tuft, known as our glomerulus. This blood then continues going around, staying in close contact with the nephron and then leaving the site. But this capillary network, this tuft of capillaries, was known as our glomerulus. Glomerulus is surrounded by glomerular capsule, or sometimes it's known as Bowman's capsule, named after the man who first discovered and named structure. So Bowman's capsule around here. What else could we talk about? Let's talk about what continues after the Bowman's capsule. After Bowman's capsule, we have this thicker part of the tubing, if you wish. This is our proximal convoluted tubule. And that runs between the Bowman's capsule or glomerular capsule and nephron loop. Nephron loop is this thinner, literally looking like a loop-like structure of the nephron. So it goes down and comes up, much thinner than the convoluted tubules that we've seen before. And after that, we get back to the convoluted tubules. This time it's going to be distal. So distal convoluted tubule runs all the way to the end of the nephron, and nephrons ended up emptying their contents to the collecting ducts. So those are the key structures of a nephron to know. Well, why do we need to know this? We'll notice when we look at the movement of fluids with the nephron. And notice that the blood vessel remains in close contact with the nephron. And of course, we have arterioles. These were just our small arteries, if you wish. So in the diagram that I provided you, I had a color difference on the blood here. Remember, there's not going to be really a color difference. I just made it to highlight the difference between afferent and efferent part. But it's all going to be arterial blood. So the first movement of fluids, and these I have marked on this diagram with letters. First place where we see movements of fluids is the filtration. So where the blood gets filtered, certain elements of it gets picked up from the glomerulus and gets put into the nephron. This stage, this movement of fluids here is known as our filtration. After we've filtered the blood and we have taken some of the fluid into the nephron, we get to the nephron loop or loop of Henle. And here, some of this fluid is actually put back into the blood, to the circulation. So from the nephron loop back to the blood. This is known as reabsorption of these fluids. After reabsorption on the distal limb of the nephron loop, we have some fluids moved from the blood back to the nephron loop, and this is known as secretion. And finally, whatever is left as a product from the nephron gets dumped from the nephron to the collecting duct, and that's known as excretion. So all of those are the movements of fluids. It would be good to know where they take place within the nephron and what the names are, so you can match them. Remember, this is an open book test, so you can keep your notes. This would be probably a good thing to highlight on your study guide, if you prefer to use your study guide for that purpose. Okay, let's have a look. Now that we've had a look through the nephron, there's a couple of points that relate to that. And the first one is going to be GFR, our glomerular filtration rate. This is a measure of how well your kidneys work. So basically, it's a test that we use to find out how much blood passes through the glomeruli per minute. We earlier on have run into this hormone known as ADH. And you remember that stood for antidiuretic hormone. Well, we learned earlier on that antidiuretic hormone made us anti-urinate, so produce less urine. But how does it do? I never explained to you. And let's have a look of how does it do that. Well, antidiuretic hormone works by making this part, the distal convoluted tubule of the nephron, much more permeable, the wall here. So all of the sudden now, a lot of this fluid gets taken back into the cardiovascular system. So that's where and how the ADH works. And now that we've covered the kidneys and especially the key part of the kidneys, nephron, we're ready to go through quickly the other parts of the urinary system. Let's start with ureters. Ureters transported the urine from the kidneys to the urinary bladder, about 25 centimeters long tube. Again, if we think of the location, they are retroperitoneal, so behind the peritoneum. They are made of smooth muscle, which allows us to have this movement known as peristalsis, which moved materials along a pathway. And it doesn't matter in what position we are, ureters always carry the kidney to one direction, from the kidneys to the urinary bladder. So even if you were standing on your head, the peristalsis, this movement, thanks to the smooth muscle layer of this tube, allows us to make this movement to this direction. Or, for example, if you're in space in zero gravity, still this movement goes this way. Let's have a look of the urinary bladder then. Well, urinary bladder really is nothing else but a temporary storage place for urine. It is a sac-like structure that's hollow inside, can expand, can shrink, depending on how much urine we've got there. Again, location, retroperitoneal, behind the peritoneum. It's located within the pelvic floor, if you wish to kind of locate it in that. What's important with the urinary bladder is that we've got this structure known as trigone. So if we think of the urinary bladder, there's 3 different tubes coming in there. And all of these enter at the base, at the bottom of the bladder. So although you saw that ureters enter the bladder, they don't do it right at the superior surface at the top. They actually go around and sneak in and enter from the base. So they are the 2 posterior openings at the base of the urinary bladder. More anteriorly, we've got an opening for the urethra. And since we've got these 3 different openings, they all form this triangular shape between them. And that's what we know as trigone. So remember, posteriorly the ureters, anteriorly the urethra, forms this triangular shape structure. And final part of the urinary system that I want to mention here is our urethra. So that's what drains the urinary bladder. The external word, again, muscular tube, and we have different sphincters here. The internal sphincters are involuntary, so you're not able to control those. But the external sphincters are voluntary, so you're able to control those. So usually we are able to hold our urine. There are conditions and aging effects and so on that the external sphincters are no longer working as well, or we're not able to control them as well. If you look at the length of the urethra, one obvious thing that we notice is that the female urethra is much shorter. This tells us that females are more prone to UTIs. How can we explain this? Well, because the distance for the bacteria to travel up is shorter, so females are for that reason more likely to develop UTIs. I do want to introduce this term, micturition. That's the proper medical term for describing the act of urination. So be familiar with that term as well. And finally, before we wrap up the urinary system, I want to mention a little bit about the composition of the urine. So we'll notice that urine is mainly water. Most of the urine is water. There's some solutes, about 5% of the volume of the urine, various nitrogenous wastes such as urea, uric acid, creatine, and then a bunch of others that I've shown here. When we look at and analyze urine, what we are looking for, is there too high of a concentration of any of these components that we normally see in urine? Or are there components that we should not see at all in the urine? What we should not see in urine are, for example, blood proteins, white blood cells, and bile pigments. If we start seeing these things, then we know that we have an issue and we need to get to the bottom of that issue. So that wraps up our urinary system. And the last chapter for us to have a look is the chapter on fluid, electrolyte, and pH balance. And really just kind of what I was telling at the beginning of that chapter was that why is this important? You need to know what's normal so you can understand what's abnormal if you get tests coming back where you have abnormal values. And as we talk about the fluid balance, we notice that most of our body is made of water. And the amount of water in a human body varies somewhere between 60-65% to all the way to 75% or so. It depends a little bit about your sex and also about your age. So males tend to have a little bit higher water content. That's because males don't, in general, have as high fat content in their body, and we end up finding that fat doesn't contain as much water as the skeletal muscle does. So that's why female water content is slightly less. We also notice that infants have a higher water content, mainly because they have a low body fat percentage. So again, but fat did not contain a lot of water, so that's not an issue for them. Low bone mass as well. And in elderly, the water content can be fairly low, down to 45% or so. So you'll notice there's a lot of variation there going. What else could we notice about the water? Where is water located in the body? About 2/3 of the water is located within the cells, so intracellular fluid. About 1/3 located outside the cells, so ECF, extracellular fluid, for example, as an interstitial fluid, blood, plasma, and lymph. Those are some examples. Water is super important for life, and we've discussed this in your introductory bio courses. So in your Bio 181 or Bio 156, you should have talked about the characteristics of water. So that's why I'm not going to spend a lot of time on those. However, these are important characteristics and they help us to understand the rest of the material of this chapter. So I will mention a little bit about those, but I don't want to spend too much time on those. So refer back to your intro bio coursework or course material if you're lost of that. I also have provided a great link to my intro bio course on this topic. On your lecture video. Just look to the end of the lecture video on this chapter, and there's a link there located. So why water is so important for life, and what are the special characteristics of water? Well, first of all, water is an excellent transport media. So a lot of things can be transported, carried within the water. Think of, for example, blood. Majority of blood is water. And blood serves so many purposes for transporting stuff. So that's one key characteristics of water. The two second characteristics that I want to highlight are cohesion and adhesion, both properties of water. And I want to be very clear about this because these sometimes get confused. So cohesion refers to the attraction of water molecules with other water molecules. So water molecules tend to be sticking together. So for example, if you have a glass of water and you overfill it, you'll notice that even though the rim, the edge of the water is lower, there can still be dome above this. This dome stays together. It doesn't break apart and start flowing everywhere because these water molecules are attracted to other water molecules. They tend to stick together thanks to the cohesive forces. Adhesion instead refers to the attraction of water molecules with other substances. So for example, if you've been driving on a car and it's been raining, you'll notice that some of the raindrops stay on the window. They don't just fall off. That's because water is attracted to the glass on the window. So water gets also attracted to other substances. So be clear about the differences between cohesion and adhesion. Next, I want to talk a little bit about the surface tension. So we all know that bugs can, for example, walk on water and so on, if they're small enough. This is because the water molecules, thanks to the cohesive forces, stick together so much that the bugs cannot break this. This water forms almost like this elastic, rubbery surface thanks to these cohesive forces. Next thing that I wanted to mention was the fact that water works as a great heat reservoir. So if you have lived at the coastal area, you notice that even if it's a hot day, the temperatures don't get that hot. That's because the body of water, whether it's an ocean or a large lake or whatever, that tends to bind some of that heat that's around. And then again, nights remain warmer. The drop in temperature isn't as drastic because that water slowly releases that heat. So temperature changes are slower where there's a lot of water. Similarly, water can be used to transport heat. We think of our blood, for example. I told how the blood coming from the core of the body and traveling, for example, to our nasal cavity was able to transport heat there. So water works as a great heat reservoir. And of course, that water that I was referring was the water component of the blood. What else? I mentioned that water can take different forms, different phases. Everyone should be familiar with the solid, so as ice, with the liquid, what we see when we think of the liquid water in a glass, for example, and then the gas form, the water vapor. There is also another form that we do need to be aware of. There's a form that can be taken, that's plasma, but that doesn't really apply to the water, applies to some of the other elements. But I've added it there so you don't forget. And final point that I want to make about the water is that water makes a great solvent. So water is known as universal solvent. So a lot of things dissolve into the water. And because water was a great solvent, it can transport a lot of materials. So you'll see how these characteristics bind together. We are not really interested on this concept about the materials that don't dissolve to water. For example, certain molecules like glucose, lipid, urea, creatine don't dissolve to water. We're looking at the materials that dissolve to water. And when certain elements or molecules dissolve to water, that causes various charges to form. So you'll notice that all of these examples that I have here have either positive or negative charges that they're carrying. And that's because when this dissolving process takes place, we end up with some sort of charges. These produce our electrolytes. So certain elements, certain molecules that carry a charge of some kind. And this is important when we start looking at the electrolyte balance. But if nothing else from this chapter, the next what I put here into the box is what I would ask you to remember. So we'll notice that if water travels from one area to another, usually electrolytes will follow this water. And same goes the other way around. So if electrolytes move from one area to another, usually water will follow. So we'll see this in practice when we have a look, for example, concept of tonicity. But water and electrolytes are interlinked. One affects another. When one moves from one area to another area, the other one usually tends to follow. So that's the big take-home message here. But before we look at the tonicity, I want to talk a little bit about the fluids. How much fluids we take in and how much fluids we get out, put out in a typical day. Well, the amounts of these must be equal. So we must take same amount of water in as we put out, or we must put out same amount as we take in, so that we maintain the homeostasis. There's no big changes. On average, it's about 2.5 liters a day. For both, of course, that varies based on the location, based on the activity level, based on surroundings, based on individual size, and so on and so on and so on. But the main source for water entering to your body is through drinking. About 2/3 of all the water that you take in is through drinking. So the thirst is the driving force for water intake. We also get smaller amounts of water through moist food and as a byproduct of metabolism. If you wonder how do we make water in metabolism, we have to go all the way back to this formula that I mentioned. What is all that your body did? All that your body did, if you want to simplify life into a great extent, was to do cellular respiration. And you noticed when sugar molecules were broken, so glucose in this example, with the oxygen, we produced energy in form of ATP, and as a byproduct, carbon dioxide. But also we are left with extra water molecules. And this refers to what we saw earlier on there, or what we saw there, that some of the water is also produced through this. So we end up with some water as a byproduct of cellular metabolism. Let's find where we were. Sorry about scrolling back and forth. Well, how do we get rid of the water? Most of the water that we get rid of is through urinating it out. About 2/3 again. In addition, some amount of fluids we lose through evaporation, sweat through the skin, for example, through breathing some of the humidity, and a small amount through feces as well. But as you will see when we discuss the digestive system at the large intestines, a lot of the fluids get taken up back to the body. So feces are not that rich in water. Next thing that I talked about with you guys was about a concept called osmoreceptor ADH mechanism. To understand that, we referred back to the homeostasis, so to the maintenance of the consistent internal environment. And I wanted you to remember this homeostatic feedback mechanism loop that we've seen multiple of times. We remember that there was some sort of a change that was detected through sensors. These sensors pass the message to the control center, usually our brain. There's some sort of a set point, what sort of normal values we expect. And if this stimulus is off from the set point, effector acts to stop the stimulus from happening. So normally negative feedback. The only times when I can think of positive feedback taking place is during childbirth, during lactation, and during blood clotting. But most of the time, negative feedback mechanism. So I wanted you to be familiar with this so that we could find a simple way of understanding what happens in osmoreceptor ADH mechanism. And I provided the explanation what happens when there's too much water in terms of all the events, all those difficult formulas, all those difficult diagrams that you would have in your textbook, simplified as a homeostatic loop here. So I leave that for you to study yourself. You can refer back to the lecture video if you're lost. And same for what happens when there's too little water in the body. So both of these are explained using this homeostatic feedback mechanism loop. So I encourage you to have a look of those. But like I said, that's left for you to revisit on your own. I want to say a couple of words about tonicity. And remember, I told you earlier on that the important take-home message of this chapter was that where water goes, electrolytes follow, or where electrolytes go, water will follow. Well, we see this with the tonicity. So we're going to be looking at 3 different kinds of tonicity. We're going to be looking at hypotonic, isotonic, and hypertonic cells. And let's start with the hypotonic cells. What happens in hypotonic cells is that the inside of the cell contains more electrolytes than the outside of the cell. And if that was the case, well, water followed the electrolytes, so water keeps flowing into the cell. And as a result, the cell grows bigger, swells, and might eventually even burst if this imbalance is too great. So how do I remember the hypotonic cells? Anything that you can do to help you remember, do that. For me, it is using images in my mind. I think of hypotonic cells, sound a little bit the word hypotonic, like hippos. Hippos are big animals. They look a little swollen. So my hypotonic cells are hippo cells. They're big, swollen cells. Let's have a look of next isotonic cells. In isotonic cells, the amount of electrolytes is same inside as it is outside the cell. And as a result of that, some water might enter to the cell, but same amount of water leaves the cell. So the overall net gain and net loss is 0. There's no change in the cell size. It remains the same. How do I remember isotonic concept, isotonic cells? I think that isotonic makes me always think of the sentence. I had a picture of that in our lecture material. Iso-perfect. If you are perfect, you don't need to change. You can remain the same. So my isotonic cells remained the same. Finally, hypertonic cells. In hypertonic cells, the inside of the cell has less electrolytes than the outside. And as a result, water keeps flowing out from this cell and the cell shrinks. It can eventually even dry up. So cell becomes smaller. Think of that picture that I had earlier on about grapes that turned into raisins. Well, how do I remember this? I think of hypertonic as people who are hyper. How are they? They have a lot of energy. What do people who have a lot of energy do? They run around a lot. What happens if you run around a lot? You become very skinny. So my hypertonic cells are these skinny cells. They become small because fluid flows out from them. How this relates to the clinical relevance, sports science relevance, think of the recovery drinks, electrolyte drinks. If you are sweating a lot, you lose electrolytes, and if you try to replace the lost fluid with just simple water, eventually you end up in this situation where you have different amount of electrolytes inside the cell as you have outside. So that would not be ideal. So for that reason, these athletes drink electrolyte drinks. These electrolytes also help with the water uptake. So that's the purpose of these drinks and something to bear in mind. And the final concept that we're going to talk regarding this chapter is going to be the pH scale. And pH scales should be a revision to you again from your chapter from your introductory bio courses. You remember that pH scale ran from 0 to 14 with the 7 being the neutral. And pH scale was nothing but a mathematical way for us to tell about the concentration of hydrogen ions in the liquid. And you can have high pH. If it's above 7, we talk about alkaline or basic substances. If it's below 7, we talk about acidic substances. So if the pH is above 7, there's a high concentration of hydrogen ions. If it's below 7, there's a low concentration of hydrogen. Well, how does this relate to everything that we have? Well, we'll notice that body pH is maintained within the very narrow range. For example, here the arterial blood typically maintained between 7.35 and 7.45 of pH. How are we able to maintain it within this narrow range? We'll have a look of 3 different reasons. But before we do, why would we maintain it within this narrow range? Well, that's because most body processes, most enzymes, most metabolic processes work ideally in this pH. So we want to ensure that we remain within this pH range. And the 3 processes that I promised to talk about are going to be listed here. So let's have a look of the quickest way of balancing off if all of a sudden our body would be changing too acidic or too basic. That's when the buffers kick in. These are chemicals that bind to acids and bases. They work almost immediately and stop this change from happening by this chemical binding reaction. Well, the second way how we can act to regulate the pH within this narrow range is through respiration. This takes minutes, between typically 1 and 3 minutes or so. And in this, we remove chemicals, elements that we don't want, molecules, through breathing them out. And the final mechanism that I want to mention is the renal mechanism. So through your kidneys, you remove, for example, hydrogen ions in urine. This takes anywhere between hours to days to act. But this is also the most efficient way to act, most powerful way out of these 3 to act. So those 3 mechanisms allow us to keep the body pH within such a narrow range. Of course, there's clinical consequences if our body pH is too high or too low, and we discussed those in the lecture video. Final point that I discussed was the concept of fluid therapy. So if we have a person who has lost a lot of fluids, we put them a drip, and that's fairly common. This drip helps us to add fluid into their body, and this drip is put to the vein, so it's an intravenous drip. What we are actually putting in is sterile water, which includes just the right combination, just the right amount of electrolytes. So we don't end up with any of these tonicity issues either way. We have isotonic cells because the amount of electrolytes is in right balance with what we want them to be. In comparison to what the body is. So that's really all that I have on this review guide. I know that it's a lot of material, but remember the format of the exam is the exact same as we've seen before. Open book test, all the questions are from the review guide, and you can take it without any proctoring. You don't need to have the responders or anything else on. So that takes us back to this PowerPoint that we saw before. We have now looked through the study guide for the exam. You have, I think, rather good materials to study for the lab practical as well. Remember, with the lab practical, there's practice practical. I would encourage you to take that multiple times because that way you're able to go through all the questions that might come up. Again, remember, you can take notes, you can take screenshots, you can have those available. I went through the lab practical a couple of times last week, and really there's a lot of structures, but also rather than just organs, more specific structures. So spend some time to be familiar with those. I don't think there was a huge amount of histology, but do spend time rather than just being able to identify kidney, for example, know the different parts of the kidney. That's just an example. There's other questions as well. I am uploading the lecture slides as handouts. It's not going to be the exact same slides that I used, but it's the ones from your publisher's textbook. I think that they're rather similar in the content, if that helps you in studying. Remember that I'm always happy to facilitate if you need an extension, if you need to have any assignments opened. I want you to get those points so you can get the best possible grade. And of course, I want you to remember that you have tutoring available both through the college, and I'm happy to also help with that. I'm gonna be really happy to answer to any questions, but I just want to remind you about these due dates that I showed right at the beginning. So for the week 10 and week 11 lecture materials, the assignments, I've extended those all the way till November 18th. And remember that this week's exam 3 and lab practical 3, it's open both this week and next week. So you have time to catch up with the studying, and you have time to have studied the material before you take an exam of that. And that brings me to the point, if you have any questions, I'm super happy to answer those. I'm happy to answer them both on the recording, or I'm also happy to turn off the recording and we can tackle those. In terms of, this is all what I wanted to cover in this review session. So unless there's anything, I'm just going to pause the recording now. If you have any questions, just let me know. I do want to help you and make sure that you'll be fine. Remember, open book, test post for the exam and lab practical, and you can take it without any proctoring.